augmentation and flap surgery, everything got healed. Then why you need to talk about these lesions? So unless you understand this whole procedure, you are not going to get that clinical success. And if you don't get clinical success, don't blame endodontics. Blame your own understanding, blame your own technique which is faulty. And that's why I am here to prove you that endodontics still works. How it works? Maybe you have to understand yourself first, your capacity. Now see this case. If you want to do such type of retreatments, you can do it. But provided you understand this case, can you do better than this? If the answer is no, don't touch this tooth. If the answer is yes, you can very well treat this case. But while removing this post, if you crack the root, what's the point in doing repeat root canal? While removing this gutta percha, if you break another instrument in that, what's the point in doing endodontics? And that is what people are doing it. And that is where I am upset. That if you are not trained, if you have not understood the endodontics, why the hell you want to treat this such retreatment cases? You can still do a better job. We removed the post, we removed the gutta percha, we treated the ledges. See the success, the lesion has healed, follow-up maybe after 4 years, complete bone is healed, lamina dura is restored, patient is doing well. This case was advised for extraction and an implant. We could avoid that. And that is what I want to pass the message. The so-called hopeless tooth, you feel we can still save that. Provided you develop a final protocol in your clinic, you develop a discipline in your clinic on endodontics. And if you develop that discipline, you will get wonders in your clinical practice. You can do miracles in your clinical practice. You need not be an endodontist for that. A general practitioner can do a good root canal, provided he is aware of all these procedures. And that's why, let's talk about one of the basic fundamental change in last 30 years. I never used ultrasonics in my 30 years of practice earlier. But last 10 years, I am addicted to ultrasonics. Because phenomenal change in my practice, phenomenal change in my approach. But first you have to understand what is ultrasonics. Why we use ultrasonics? What is the action of ultrasonics? It's not like a rotary instrument where you pick up that and start using it on the tooth. There has to be first understanding on ultrasonics, which I am going to explain it. There are 3 types of ultrasonics available in the market. One is sonic scaler, one is piezo scaler, and one is magnetostrictive scalers. All we use is piezo scalers, and those only piezo scalers are used in endodontics. You cannot use sonic scaler and magnetostrictive in endodontics because of the action of that instrument. So what do you mean by piezo scalers? Let's understand what is the action of that particular instrument, which is very important for endodontic use. See this, sonic moves in a round action. So nothing round in ultrasonics in endodontics. Then comes, this is a round action. Then comes piezo scalar. How piezo works? It's called linear action. It's only in one line. And that is expected in endodontics. This action you can use it in root canal and endodontics. And that's why magnetostrictive, which is also called elliptical, is not recommended in endodontics. We don't want any round rotary, we don't want any elliptical, we only want linear action. And these are the piezo scalers which are available. So you have to see which piezo scaler you are using it. Once you select the scalers, then comes your machine. Now we are so used to using scaler, removing tartar, calculus and stain at the power of 10 and 11. It is contraindicated in endodontics. You should never use any ultrasonic tip at 10 power and 11 power. All you should use it at 1 and 2 as a beginner, maximum 3. That is a fundamental understanding of ultrasonics in endodontics. If you use higher powers, those tips, any tip, it's an Indian tip or imported tip, all tips will break at the higher power. So you have to be very careful as the selection of that particular power. Applications, where you can use ultrasonics. There are n number of applications in endodontics. Few applications I would just explain you, and I am going to show you some of the clinical cases. First is removal of crown and post. You can use ultrasonics. Access cavity preparation, refining of access cavity preparation, locating extra canals, MB2, D2, you can use ultrasonics because we are so used to using air rotors for locating those canals. We are so used to using high-speed instruments to access cavity preparation, and in that bargain, you overcut the tooth, you perforate the furcal area. These are the common problems with air rotor, which we have minimized with ultrasonic tips. Removal of pulse stones, locating extra canals, treatment for ledges, we use ultrasonics. How to use that, I will go in details. It's only 1 hour lecture, so I have a lot of limitations. I may not be able to explain you everything, but things which are important for your clinical use, maybe I'll show you that. That will help you in your day-to-day practice. Removal of gut aperture, we use ultrasonics. During obturation, we use ultrasonics. Removal of broken instruments, removal of silver cone. Earlier we used to obturate the canal with silver cone. So there is a technique called indirect ultrasonics, which you use it with ultrasonics. Packing of MTA during retrograde fillings, all episectomies should be handled with ultrasonics. No episectomy should be done without any retrograde fillings. If you are going to do any curettage, you have to seal the apex from the apical area, and there ultrasonic comes in the picture. Treatment for perforations, all ultrasonics which are used inside the canal, microscope is preferred. In the chamber, you need not use microscope. Without microscope, you can use ultrasonics. But as you go in, you need a magnification, and then microscope becomes mandatory. You should never use water while using ultrasonics, because in scaling we are so used to use water spray. In endodontics, water spray is contraindicated. You should always use without water for a better vision. Now question comes, protecting a pulp, because in endodontics we don't have to protect the pulp, so there is no need to use water spray. Intermittent use of ultrasonics is recommended. If you feel your teeth is getting heated, you can stop for 10 seconds, again work on the patient, again stop for 10 seconds. That's the best practice to use ultrasonics in endodontics. Heat generated during ultrasonics clinically is not significant. Maybe there is a heat generated, but if you use intermittent use, you need not worry about that. Axis preparation, one of the biggest challenge in endodontics, where most of the people miss some canals. Either you miss MB2, D2, extra canal. This is a routine scenario in your day-to-day practice. I'm sure you must be facing this problem. So there is a solution for this, and that is straight line axis, mirror test, and 10 number K-file test. If you want to achieve good axis cavity preparation, how do you know that you have axis cavity preparation is properly done? What is the criteria to decide that your axis cavity is having good straight line axis? There are 2 tests to be followed. One is mirror test and one is 10 number K-file test. If you follow these 2 tests, you can be sure that your straight line axis and your axis cavity preparation is properly widened. You will not miss anything in your axis cavity. Now what is this mirror test? All the canal orifices and pulpal floor should be visible without moving the mirror. When you put a mirror on the tooth, you should see all palatal canal, distal canal without moving the mirror. In one go, you should see all 3 openings. See this. I am putting a mirror on the tooth and I can see all 3 openings in one go. If I have to tilt my mirror for lingual canal or distal canal, that means straight line axis is not achieved. This is called mirror test, which is mandatory for every axis cavity preparation. And second test is 10 number K-file test. What is 10 number K-file test? I will show you video film. See this tooth. This is called mirror test. Without tilting the tooth, I can see all 3 openings in one go. That means I have achieved straight line axis. Now what is next test? 10 number K-file test. What is 10 number K-file test? Put 10 number in each canal which you have found, and that file should not touch any of those walls. If that file is touching any of those walls, that means straight line axis is not achieved. You need to widen your axis cavity preparation. Just see this. My 10 number file is touching the wall. That means I need to refine this axis cavity. This is called refining of axis cavity preparation. Buchanan says file should dance in the chamber. That is the right thing. That is called coronal interference. Whenever file is binding to the wall, that is called interference. And Groundon says you should not have any coronal interference. If you follow these 2 tests, you can have a good axis cavity with a straight line axis in your day-to-day practice. You will not miss any canal at the pulp chamber level. See this distal canal. The file is dancing in the chamber. That is called straight line axis. This is mandatory for every access cavity preparation. If you miss this, believe me, you will break all the rotary instruments in your clinic. One of the major reasons for breaking rotary instruments or any file is lack of straight line access. And this is the straight line access which you have to achieve. After achieving good access cavity preparation, every clinician should understand what is cervical dentinal triangle. This is one of the major hindrances to reach the apex. Every root canal has cervical dentinal triangle. And this cervical dentinal triangle needs to be located by every clinician before starting a root canal or at least after access cavity preparation. This is a major hindrance in a mesobuccal canal to go to the apex. To achieve straight line access, we need to identify this cervical dentinal triangle. And this understanding of cervical dentinal triangle is very crucial in every endodontic procedure. I am launching these two tips for Indian dentists because all ultrasonic tips which are available in the market, they are so exorbitant that I myself cannot afford that particular instrument in my clinic. So one day I got up and I started designing these two tips, and they are available in India now. These are the tips to use it on one of the scalers which you have to locate the MB2. This is animation to make you understand that if there is any pulse tone in the chamber where you cannot locate any canal, instead of using aerotor and making more overcutting of that particular area, you can use ultrasonic tip. Just vibrate that tip around that around that particular pulse tone, and you will see the canal which is hidden below the denti will get exposed. We are so tempted to use ultrasonic aerotor in such cases where you try to perforate, or sometimes there is a thinning of furcal area, which is a major challenge in endodontics. So you can minimize with this procedure. I'll show you some of the clinical cases with some demonstration. See this case. During hands-on, one of the participants couldn't find the canal. He overcut that particular area. This is called overcutting. Any white dentine is called wall. Any brown area is called floor. Always try to maintain the map of the dentinal map. And that dentinal map is identified as a brownish color. So all this brown area was overcut. So we decided to stop that aerotor, and we started with eye super tip, which is now, this is 30 number eye super tip. And we started digging with the ultra. See the conservative cutting. See the vision. Because of the design, you can actually see the perforation, you can actually see the location of the canal, you can actually see a broken instrument. That is the beauty about this instrument. With aerotor handpiece, your whole view is blocked because of the head of that handpiece. So you can't actually see anything. Believe me, whoever is using aerotor, they can't see anything while you doing access cavity preparation. They are doing access cavity with randomly. That everyone will agree. Because of the design of that handpiece, that is the head of that handpiece. And see the design of the ultrasonic tip, you can actually see where you are cutting. And the cutting is so conservative that there is no chance of perforation, there is no chance of any overcutting of that particular area. In fact, you will locate that canal. Just see. See the palatal canal. See the distal canal. See the mesobuccal canal. A very rare pulp chamber in lower second molar, upper second molar. And now the picture is clear once you use ultrasonics in these cases. See now, while cutting this, I have not touched any other tooth structure. The tooth is conserved. That is the purpose of access cavity preparation. If you try to use aerotor at this stage, believe me, either you will strip the furcal area or you will perforate somewhere else where the canal is not located. And this is a typical problem in endodontics. Another case I will show you how to locate MB2. Everybody is so apprehensive about locating MB2. See this, there is MB1. See the ultrasonic tip, this is eye super tip 80. For bigger canal you can use 80 size, thinner canal you can use 30 size. This is MD1. On that line, draw a line between MD1 and palatal. Outer side of that line, go on digging with ultrasonic tip from your canal towards palatal area, and you will find some black spots and white spots. That is MD2. Only with conservative cutting you can locate these canals. It is not possible with air rotors. It is not possible with high speeds. Study the dentinal map. Make a habit of studying this dentinal map effectively. Every white spots and brown spots in pulp chamber indicates of calcification. All calcification means pulp tissue. That means there is a chances of extra canal in that white spot. Try to dig those white spots and black spots with these tips. And you will be surprised to see extra canals in these areas. Earlier, I couldn't imagine there is extra canal here. But now I can clearly locate extra canal. These are the advantages of these instruments, where you can locate all the possible hidden canals with this procedure. This is 30 number, this is 80 number. Initially you have to see which scaler is matching, because there are two types of scalers worldwide. One is Satellac and one is EMS. So both the types of tips are available. Satellac for S, EMS for E. So according to your machine you have to ask for that particular instrument. There are different tips available in the market which are used to remove the post and core. Whatever crown is stuck with the tooth, you can remove it with ultrasonic tips. But they are expensive and really expensive. Maybe you should know what are their uses, how to use them. So these are the tips which are available. I used to use them earlier. Last 20 years I have been using these tips, but I found them very expensive, and that's why I come out with my own high super tip for Indian dentists. This is to remove the post and crown. This is to remove and refine the access cavity to achieve straight line access. This is to go into the furcal area and the locating the canal, and this is the inside the canal. If there is a pulse stone, you can remove that. Different uses. Ultrasonics are contraindicated in cleaning and shaping. Don't think you can do shaping with ultrasonics. Ultrasonics has limitations, and one of the limitations is you cannot shape that canal. You can use it for multi-purpose, but shaping is done with rotary instrument only. So there is no substitute to rotary instrument. But there are so many other uses where you can use this ultrasonic tip, and you can make your endodontic procedure more conservative, and that is the purpose of this. Maybe I'll just go quickly to the other applications, because it is 2:30. I have only 30 minutes now. Out of that, we'll have 5 minutes question answers. So I may not go into each application in detail, because that becomes 3 hours lecture. So I have to just go to some of the procedures. How to remove broken instrument? One of the biggest questions asked after every lecture and every course, that doctor, tell us how to remove the broken instrument. The question is, you need to understand the discipline, the protocol, the understanding of that instrument, understanding of the anatomy, then comes how to remove the broken instrument. You can't buy any tip and start removing broken instrument. Sorry. There is a thinking behind that. And that thinking, I would just explain you quickly. First, you need a guesswork. You need some luck to remove that broken instrument. But definitely there is a technique involved. I don't say that it's only luck which helps in removing the broken instrument. Maybe 80% is your technique and 20% is guesswork and luck. So what do you mean by luck, and how the factors affecting that broken instrument? How do you decide that you can remove that broken instrument or you cannot remove that broken instrument? There is some understanding of that particular case. So these are the factors. If you understand these factors, you can very well decide, that I can remove this broken instrument or I cannot remove this broken instrument. Factors is location of the instrument. Apical area, tougher the case. Coronal area, easier the case. Anatomy of the canal, beyond curvature, tougher the case. Earlier than the curvature, easier to remove. Size of the instrument, larger the instrument, tough to remove. Thinner the instrument, easy to remove. Length of the instrument, longer the instrument, tough to remove, because more binding. Shorter the instrument, easy to remove, less binding. These are the philosophies and the maturity of clinician. Have you removed any broken instrument earlier? Then it's easy. If you have not removed a single instrument in your life, it is tough. Any first experience is going to be tough. So don't think that it's easy, but definitely you can do it. Try to learn, try to understand these philosophies, techniques and the instruments. Use of microscope is definitely preferred. Essentials of broken instrument. You need a microscope, you need ultrasonics, you need straight line access, you need understanding of radicular access, you need a training for that. You just can't buy that instrument and start removing a broken instrument. And lastly, you need a time. It takes 1 hour to 3 hours to remove a broken instrument. Don't think it will come out in 2 minutes. If it comes out in 2 minutes, that means you are lucky. But you may not be lucky every time. So sometimes we take 3 hours. So we charge according to the hour. Per hour we charge to the patient. That more the time, more the charges. Patient has to accept that. Diagnosis. Again, there is a big confusion around broken instrument. People get panic when they see broken instrument, which is not required. There is no panicky situation. Just see one patient got a severe pain in the night. Whole night he couldn't sleep. He came to a dentist early in the morning at 10 o'clock. Dentist took an X-ray and he saw a broken instrument in the periapical region. The dentist said, "Oh my God, there is a broken instrument in the bone. Now you'll have to remove this broken instrument, do something, go to Dr. Naware and get it removed." Patient came at 12 o'clock to my clinic with a bad pain. I saw everything. I said, "When was this root canal done?" He said, "Maybe 10 years back this root canal was done." One should understand, if the instrument is there for 10 years, it is not giving any lesion, how it can pain? It has to be another tooth. So I did a root canal for the next tooth and the pain went off. So why you unnecessarily become panicked by seeing the broken instrument? You have to understand that there is a philosophy, there is an understanding of every broken instrument. And if you don't understand that philosophy, you are stuck. You will go with the wrong diagnosis. And believe me, 50% of broken instruments are wrongly diagnosed. Dentist doesn't know what to do. Randomly they do something and the case becomes chaotic. Believe me, I have been seeing these cases. I am absolutely upset with these cases. Yeah, see this instrument. I really appreciate how he must have broken this instrument. 40 number K file is broken in central incisor. You really require a skill to break such instruments. But the question is, there is a lesion there. It has to be removed. You can't keep this because there is a lesion. There is no lesion here. So there has to be a differentiation between every broken instrument. How to remove broken instrument? Now believe me, I am going to show you a technique. You know, there is an ad of a motorcycle in TV. Don't try these stunts. It is underdone with supervision and all those instructions. Same thing. I am going to show you something. Don't try it without any supervision. Okay? Be careful. I am warning you. But you should know how to remove broken instrument. You should know how to use these ultrasonic tips which I have developed. Eye super tip, you can use it for this procedure. By any chance, if you break any instrument beyond the curvature or at the apical 1/3 or maybe middle 1/3, improve your straight line axis. Now you know what is straight line axis. Mirror test and 10 number K file test is mandatory for removal of this broken instrument. Once you achieve good straight line axis, improve your straight line axis inside the canal, go to the broken instrument and improve your coronal interference. Now you should know what is coronal interference in crown dot technique. You should know these philosophies. Then only you will understand and then only you can attempt on this tooth. Then you pick up your Gates Glidden. It is called modified Gates Glidden. Use air outer to make it half. That is called modified Gates Glidden. Take that modified Gates Glidden, tilt the broken instrument and you create a staging platform. It is called staging platform. You create that staging platform. So staging platform will give me a space to use my eye super tip at the broken instrument level. Once I create a staging platform, I will pick up my eye super tip 30 number because 30 number is used in molars, anteriors, maybe 80 number, but most of the time we break instruments in molars. So 30 number eye super tip will be taken to the broken instrument at the staging platform anti-clockwise because we always break the instrument while moving clockwise. So it is locked only clockwise. So you have to unlock that instrument by anti-clockwise. It will pop up like a bullet. And then you can treat it like a fresh root canal. Then there is no other different procedure. Once the obstruction is out, then you can treat it like a routine. Time up?
No.
Another 20 minutes. I hope we have 20 minutes. Because sometimes they give signals. I have to learn from this. Coronal 1/3, easy to remove. Middle 1/3, still you can remove. Out. Apical 1/3, second molar, upper tooth, distal root, the apical area, one of the toughest area to remove. Still you can remove it. Out. Technique is same. Approach is same. Discipline is same. Understanding is same. Maybe anatomy is different. But for that you need understanding, you need experience, you need training, you need practice. Again, eye super tip which I have developed, it is called multi-purpose ultrasonic tip, which is to be used to locate the canals, to agitate the sodium hypochlorite and EDTA which is put in the canal. And the third use is broken instrument which I have already shown you. And the fourth use is warm gut aperture technique which I am launching for Indian clinics, where all warm techniques are dependent on gadgets, they are expensive, they are technique sensitive. So I thought it is not meant for us, where we are still struggling to understand cleaning and shaping. How can we spend time and money on obturation, where we have not understood basic cleaning shaping procedures? So I thought let's make it simpler. So I am launching eye super tip for warm gut aperture technique. See this procedure. You have to use resin sealers, no doubt about that. Cone fit, I will show you how to select the master cone. Again, there is a lack of understanding among clinicians regarding how to select that master cone. Everybody picks up GP point and they try to put in canal and they take one X-ray and they say, oh, I have done a fantastic root canal, but the lesion fails, the root canal is failed and the tooth is extracted after some years or some months. Why this thing happens? Because you don't know how to select that master cone. That is called linear tuck back. That linear tuck back needs to be understood clinically. And for that, this is a video film to show you how to go ahead with that linear tuck back. Select non-standardized GP point. Never use standardized GP points. Never use color-coded GP points. Use non-color-coded GP points. They are better, they are softer, they can deform. Color-coded GP points are harder, they are not good for tuck back. You will never achieve good tuck back with any color-coded. If your GP is colored yellow, red and blue, that means it's a bad cone. If GP is not colored at all, that is where you are required to choose. Pick up GP point, whatever canal you have shaped, whichever taper you have given, cut 2 millimeter or 1 millimeter randomly for every non-standardized GP point, that's a rule, and put it in the canal. If your length is 18, your master cone should go 18.5 or 19. It cannot be a short. Let it be overextended. That will ensure you are reaching the apex. That will ensure your apical fit. And once it goes beyond apex, then you can cut another half a millimeter every time till you get 18 length in your working length. Just see this. That is called true linear tuck back. My length is 18. My GP is 18. I'll put a mark on my GP 18. This is my working length. And I'll try to put it in the canal. It won't fit initially. It may go 19. It may go 20. Anything. Let it be. It can't be short. Overextended GP is preferred because you can cut it. You can afford to cut it. But underextended GP is not at all preferred because your true tuck back is questioned. Just see this. See, my GP is going beyond 1 millimeter of my reference length. So my GP is 19 and it is showing. On patient it will show on X-ray. So you can take X-ray to confirm. Then cut 1 millimeter. Whatever overextended. Suppose my GP is 20 millimeter. Cut 2 millimeters. So you achieve apical binding. And that is called true tuck back. If your GP is not overextending, your linear tuck bag is questioned. Keep it in mind. You should have a suspect on your apical tuck bag. Coat it with the last file use. Go anti-clockwise. Use resin sealant. Zinc oxide eugenol will no more use because it is water soluble. It degrades after 2 to 3 years. It dissolves after 2 to 3 years. So we need something which is not degradable even after 10 years. So resin sealant becomes important in modern endodontics. See the alligator puff because of the tuck back. This overfilled sealant is highly recommended in modern endodontics. That ensures you have reached the apex, you have sealed the apex. That's a certificate given by the tooth that you have done a good job. Maybe I won't go into detail, I'll just show you a video film on how to use ultrasonics in obturation without spending money, without getting any training. Still you can achieve warm gut aperture in your clinic with eye super tip which I have designed. These are the different techniques and systems available in the market. They all are expensive. They all are technique sensitive. This is an animation to explain you what is warm gut aperture technique. Select your master cone. Finish your lateral condensation. Finish like a routine root canal. Shear it off. Normally we send patient home after this. Now you pick up your ultrasonic tip and just vibrate at the tip of the gut aperture, at the beginning of gut aperture at orifice. So heat will be transferred 4 mm. Pick up your spreader, create a space, add another ultrasonic tip at that 4 mm. Your heat will be transferred another 4 mm. The space will be created by spreader again. That's all. The whole lateral canals, everything will get filled and the gut aperture will be flown inside without any special gadgets. You just need one ultrasonic instrument and one eye super tip for warm gut aperture technique. See this video film. That was the animation. This is a demonstration. Selection of master cone. See the space around master cone. See how much space is available. So you need to put additional cone, that is called lateral compaction. Do lateral compaction like a regular procedure, nothing special. This I learned from Singapore University. This warm gut aperture technique is taught in Singapore University. Half of the Singapore practitioners are using this technique. So I thought India also should follow this simple and effective warm gut aperture technique. And that's why I am launching this. Shear it off like any heated instrument. No special instrument is required. With cold rain you compact like routine compaction, vertical compaction. No special instrument is required. Now, normally we send patient home. Now we will pick up ultrasonic tip and we will just go close to the gut aperture mass. We won't condense, we won't compact. We will just take that tip closer to the gut aperture. So the heat is transferred by 4 mm because gut aperture is a heat conductor. Then you put a spreader and you compact that warm gut aperture. The gut aperture will become like a liquid. You can actually see gut aperture is getting softened. You can actually see the gut aperture is getting liquefied because of the heat of that ultrasonic tip. Create a space with spreader and you add another cone. So-called well-filled obturation, you will add another one cone and that is more than enough to fill up that micro spaces. That's all. If you do this much condensation also, it is more than enough to achieve 3-dimensional obturation. This is my center where I train all these techniques. I have been running this academy for last 18 years. We teach basic endodontics for beginners, advanced endodontics for those who attend basic course, micro endodontics, removal of broken instrument and everything. My journey from 2000, maybe my private academy we started in 2000 in Thane, and now all over the world people are coming and learning root canal. My trained, well-equipped center at Thane, where people can learn these techniques, understand better anatomy, better procedures, final protocol, discipline in your day-to-day practice you can understand here. I started a repeat root canal center, exclusive repeat root canal center in Mumbai 2 months back, where I deal only with failed root canals, broken instrument, perforations and chronic lesions. I don't do any other thing because I am so busy with those cases. So I have been setting up this center. 2 months back I started in Lower Parel just to promote endodontics. My only aim is we can save that tooth, then why not? If you don't have any guidance, we are there to guide you. But instead of removing that tooth and putting that implant, why not save that tooth? That is my question. And ultimately, if you remove the tooth because of your ignorance, who's the loser? Patient is the loser. He is going to lose the tooth just because you don't know endodontics. Just because you don't know how to find MP2. You don't know how to find that extra canal. That's why endodontics is failing and patient is suffering. So we are there to promote endodontics. That is my purpose. We do whole day repeat root canal cases with a good team. If you have any queries, you can visit integratedendo.com regarding my courses, regarding curriculum and everything. I have 10 minutes to answer your questions. It is 2:50 now. By 3 o'clock we'll stop. So another 10 minutes you can ask as much as you want. And that is where my purpose was to promote endodontics. And I hope it will help you in your day-to-day practice. That is what my efforts are. And if you don't have queries, you can have coffee. You have 10 minutes free time. Mike.
Hello. Yeah, we'll start with the question and answer session.
Anish, you are using super tape for warm gut aperture.
Yeah.
Can same be used to remove old gut aperture?
Yes. In the initial slide where I showed applications of ultrasonics, I have written removal of GP tags. So you can use ultrasonic tip to remove also. Yes.
Second thing, while removing the broken instrument, do you use water spray?
No, water spray is contraindicated in ultrasonics in endodontics because if you use water spray, you won't see anything. And if you don't see anything, how you are going to cut? Then what is the use of conservative approach? So never use water spray, use intermittent use. And we use water spray in scaling because we want to protect the tooth. We want to protect the pulp. That's why we use water spray. In endodontics, pulp is already damaged. We don't need to protect periodontium because the heat generated is not going to be a boiling heat or it is not going to be red hot heat where you are going to burn the periodontium and you are going to make the tooth mobile. It doesn't happen. Use intermittent use and that is effective.
Secondly, you are using a modified gate.
Gate slitter, yes.
Does it form a ledge over there?
No,
Using that?
See, I told you this modified gate slitter, you cut it into half. So it becomes a flat surface. So wherever you are going to remove a broken instrument, take that gate slitter and tilt the broken instrument. So there is no chance that you will create a ledge. In fact, you will create a flat staging platform. It is called staging platform. So chances of ledges are less unless you use wrong size gate slitter. Suppose your canal is 2 GG size. If you use 5 GG gate slitter, it may create unnecessarily overcutting of that area. But that is where your understanding will come in the picture that if the canal is thin, I will use 2 number gate slitter, I won't use 5 number gate slitter. So there your training is required. You need to learn from hands-on process.
Yeah, as you said, you have to judge the length and as well as you have to select the gate slitter, the size of the gate slitter.
For that you need to attend hands-on courses, because we actually teach you to remove the broken instrument. You have to remove that broken instrument in front of me on one of those teeth. So that will take care of your understanding of that anatomy. Yes.
In calcified canals?
Yes.
ultrasonics help?
Yes, of course, it is meant for calcified canals. I showed you one calcified chamber, which I destroyed that whole chamber and I located canals for you. There are 2 video films shown. It is mainly for calcified canals, where we use aerators and all high-speed instruments, which are more dangerous. They overcut the chamber. So they are meant for that. That is what I am trying to shout. That is why I am screaming.
Yeah. Always remember that the calcification starts from the chamber. It is not that in the middle of the root you will get the calcification.
Yes.
It always starts from the chamber, and then it goes coronally, and then it goes forward.
So apically it is never calcified. So whenever you stuck apically, it is mainly curvature and not calcification. Because people call me up, Dr. Naware, I am just 2 millimeter short, I think canal is calcified. No, canal is never calcified. He thinks it is calcified. You are conveniently declaring an excuse, oh, canal is calcified apically, I am not going to reach the apex. This is an excuse given by yourself to you. That's all. Whenever you get stuck, it's a curvature. Pre-curve the 10 number file and treat the ledge.
Sir, what is the drawback of using heated periodontal probe for vertical compaction? Can we use that?
You can. There is no drawback. Only thing you should know how to use that. You need a technique for that. You need a training for that. You can't just buy that probe and heat it and do it. It will not work. There has to be a 1, 2, 3, 4 steps for each procedure. You can use it.
And what about the rotary brush for activating the irrigants?
Yes, you can use that, but they are expensive.
Are they available in India?
Yes, they are available.
Which?
Yes. I think Coltin has that. Coltin has that, but they are expensive. 100 rupees each brush. I can't afford when I am charging. Average root canal charges are 2000 rupees in India. I am talking about average. How can you spend 100 rupees only on agitating that solution? Economically, it is not possible.
Is that brush is a single use?
Of course, it is single use. How can you autoclave them and use it again? Plastic, you can't autoclave. It has to be single use.
We can have calcified canal till cervical third of the...
Yes, of course. Calcification starts from pulp chamber and travels to half of the canal, coronal half.
Thank you.
Yes.
So can you throw light on how to use the super tip for agitating sodium hypochlorite?
Actually, there was one video film which I missed. There is a eye super tip where is a film shows how to agitate that sodium hypochlorite. You have to pick up eye super tip, whatever your working length, always agitate sodium hypochlorite EDTA after completing cleaning shaping. Never do before cleaning and shaping. Once your tooth is ready for obturation, pick up eye super tip, whatever working length, suppose 18 millimeter is your working length, minus 5 millimeter, 13 mm, you put a rubber stopper on the tip and just hold that eye super tip for 1 minute. That's all. The whole canal will get agitated and the remnants of pulp tissue will come out. So always use eye super tip before obturation, after cleaning and shaping, 5 millimeter short of working length. Passively, it should not touch the wall at all, and power for agitating sodium hypochlorite or EDTA with ultrasonic is 1 or 2. Never agitate at 7 and 8 and 10 thinking that it will agitate more.
Also, they say that warm sodium hypochlorite works better.
Of course.
So,
Today's lecture is not on sodium hypochlorite, so I couldn't elaborate on that. Always use warm sodium hypochlorite. It gives 10 times more efficiency than cold sodium hypochlorite.
So when you use it with the super tip, it must be warming up the hypochlorite inside. So then even if we use it like a regular temperature and then imagine.
You gave the answer. Good. So if you use ultrasonics, it is going to warm the sodium hypochlorite. So indirectly you are heating the sodium hypochlorite. That is the purpose. Use it.
Sir, I have a question.
Yeah, anyone else? Please raise your hand.
My query is related to the utilization of ice.
You just take the mic.
Sir, you just mentioned about using the isopotip for GP-tag removal. So I wanted to know how to use the tip for obturation as well as for removal. They are very closely
I I showed you a demonstration on obturation.
Yes.
You'll have to attend my hands-on course for removal of gutta percha.
One query, sir.
Yes.
When the temperature increases, the GP is kind of soft.
Yeah.
There's a good chance it can come out along with the tip.
Yes.
So how to handle that?
Yep. That is why there is another topic, another demonstration.
More detailed.
Yeah, naturally.
So that is possible.
It is possible, yes, of course. We remove all the GP tags only by ultrasonics. My whole practice is converted into ultrasonics. My n number of uses I can show you with ultrasonics. But this is an introductory lecture. In 1 hour I can explain you only this much. I can give you a lecture for 6 hours only on ultrasonics with detailed application of each tip on each procedure. There is a detailed lecture. This is just the introductory lecture. I am sorry for that.
No, I'll take the mic. It's fine. Can I?
Mic, please.
Yes,
Please.
can I just ask you a question?
Okay, you have a mic, so I have to answer you.
Sorry. Yeah.
Next.
Okay, I just wanted to ask you. See, at the beginning, near the beginning, you said that if you can reach the apex, then you can save the tooth, even
Yes.
if there's a lesion.
Yes.
So I just want to ask you, because of the lesion, probably there will be periodontal ligament will be compromised, and wouldn't that be a limitation to saving any tooth? I mean, can you tell the patient that it can be saved even though there's a periodontal?
Of course. What you are talking about periodontium, when there is a 1 centimeter and 2 centimeter of big bone loss and the damage of a bone, why you are worried about that 1 millimeter of periodontium in the tooth? I don't understand. You are unnecessarily diverting your concentration on other things and not on the root canal. If you can reach the apex, even external resorption, internal resorption, any chronic lesion, you can save it, provided you reach the apex.
Even if the tooth is slightly mobile?
What mobility? What you are talking about? Mobility is a edema in periodontium. Once you start root canal, edema will get drained. Your tooth will become firm in 48 hours. Why you are giving unnecessarily important? That is what I am giving you a message, that unnecessarily dentist is talking something else.
Yes.
And they are diverting their concentration from endodontics to other things, and they say, oh, I don't get response, and we remove the tooth. This is where I am here to give you a message.
Yes.
That try to concentrate on fundamentals of endodontics rather than talking about mobility and periodontium. Like one periodontist got up and said, Dr. Naware, I saw 1 millimeter of sealant going beyond apex. I said, why the hell you are worried? I am saving the tooth. When the lesion which is 2 centimeter, I could save that tooth, I could avoid episectomy, I could avoid bone augmentation, I could avoid 15 mm of implant in the bone. Why the hell you are worried about 1 millimeter of sealant going beyond apex? What is the big deal about that? But going that 1 millimeter of sealant beyond apex ensures me I have done a good job. I have reached the apex, I have sealed the apex, my success is guaranteed. So that 1 millimeter of torture to periodontium is desirable. Please concentrate on endodontics.
Yes.
I am warning you, if you really want to have a good success rate in your clinical practice, everybody is doing root canal, everybody is so-called successful, but there is a failure rate. Reduce your failure rate by understanding these philosophies. You may be having 92% success rate.
Yes.
Achieve 95% success rate. So you should understand why that 8% failure rate is in there in your clinic. I am trying to reach to 100% success rate. I will try.
No, it's very good news, because even if we can't do it, at least we can refer the patient to you.
No, but I am telling you, you can do it.
Yes.
Don't refer to me,
Yes,
but
yes.
learn from me.
At least we can give the patient some good news.
Of course, there is a good news for endodontics and the
Yes.
whole population.
Yes. Yes. The other question was, see, when you're using the thermoplastic method, no, of the GP point and heating the GP point, I was just wondering, isn't there a small chance that the melted GP, almost melted GP,
Which GP?
that GP point which was almost in the melting stage, no, because of the heat
Yeah.
from the eye tip during thermoplastic procedure, isn't there a small chance that it will overshoot the apex?
Not at all. That
No.
means your true linear tuck back, you have not understood. What I was talking about, how to get that true linear tuck back. If you have a strong resistance to a gutta percha, it will never extrude beyond apex. If you have a loose gutta percha, what you are talking is right, but that is not the technique. That is what I showed you one whole video film only on selecting a master cone. So what you are there talking is right, but you are wrong. Because your master cone you are not understood. That's why it is going beyond apex. And that's why earlier, maybe 30 years back, whenever we used to do lateral condensation, every GP used to go beyond apex. And we used to wonder why things are happening like this. But there was no one to tell us that time. Today, at least by paying money, you can learn techniques from us.
Okay.
And you can get a good understanding of endodontics.
Yes. Doc, last question. Suppose somebody comes to you for a regular root canal, no? Suppose somebody refers to you or something. Just want to know what are your normal charges, just for approximate idea.
This is a very embarrassing question.
Is it? Is it, doc? No.
This lecture may not be meant for all that.
No, I just wanted to, or should I call your clinic and
I
ask?
will take a permission of a chairperson. Can I mention my rates?
Just normal rate, doc, because I just want to know, suppose, others I'll have to call your clinic, is that okay?
You call me.
Okay.
This is a very embarrassing question.
It's not embarrassing, doc. I mean, you're a good endodontist, why not?
I don't know whether good or bad. but
Okay, thanks a lot. Bye.
Charges would be
topic like the endo will go on here.
Yeah, the request is please restrict to the subject.
The charges can be anything. From 2000.
Anybody else?
Or 2 lakh.
Yeah, he wanted to ask.
Right?
Right.
Now, if Anish is getting
Yes.
a big industrialist where he has to keep his 7 chairs or operator is closed for 1 hour, he may charge 1 lakh rupees for 1 endodontic treatment. That's possible.
Yes.
Nothing of that sort. We have to understand that. Now the question is, whenever you fix up your charges, it is not what you do. It is for how you do it. Like I remember a story, there was a big factory, Reliance, 20 engineers were trying to fix up the boiler. They couldn't do that. Whole day they spent.
Yeah.
And then there was a craftsman who is walking. They call him, can you fix up this problem? He said, yes. And within 30 minutes he fixed up the problem. He said, give me 1,000 rupees. He said, for what? Because he has only hammered at one place. He said, I will give you the bill.
Yes.
The bill said,
Yeah.
50 rupees for hitting the hammer,
Yes.
950 rupees
Yes.
where to hit it. And that is what makes the difference.
Yes.
So don't ask these questions,
Yes.
what should be your rates?
No,
Your
that's
rates will be based on
what I asked was not what should be your rate. I asked when I refer a patient, the patient will ask me how
your
much you'll
rates will
charge.
be based on
Yes.
your skill in your own fingers.
Yes.
Maybe we'll talk on phone. You call me up.
Yes, sir. Yes. Simple answer.
Around 20 years back, Iso used to sell this product called ultrasonic files, and it used to be wonderful experience. But after all, they discontinued. Would it be more appropriate to call it endosonic rather than ultrasonic?
Maybe, right?
More appropriate.
You can call it.
And where are these items available?
They are available with Prime Dental. Prime Dental
Okay.
products. They are my distributor all over India. They will be. If you have any problem getting the material, you just call me up. I will make it arranged to you in your clinic. Absolutely no problem. That is my duty. So,
Yeah, okay, I think this
thank you, Anish. 3 o'clock. Thank you. Dr. Sharad Kokande, thank you. It was honor having you here.